Good afternoon, everyone. Today, we continue with the most proactive question in all the public health. If you remember the question in the part 1 last lecture, we asked, do people choose their own health? To complete the answer of the question, let's begin by the central challenge. Here is the heart of the matter, the challenge that defines modern public health. Guiding people's behavior in a healthier direction is enormously difficult because United States of America live in a democratic society where every intervention is loaded with political, economic, and moral controversy. The question becomes, how do you persuade free people to behave more healthy? Historical government has two tools: education and regulation. In this lecture, we cover these two tools. And let's start with the gentle one, education. Education, at its simplest, just means informing people about what's healthy and what is not. And it genuinely works for many people who care about their health. The classic example: in 1964, surgeon report Smoking and Health, the first authoritative federal statement that smoking causes cancer. Its impact was real. Many people quit, and for the first time, smoking rates began to fall after 1964. Education also shows up in how we are taught to eat. Let's look at that. The federal government for education and nutrition, federal government has long been America's nutrition teacher. In the early 90s, 1900s, the focus was deficiencies, figuring out how much of each vitamin and minerals we need, which give us recommended dietary allowances or daily values. The FDA pushed this further by requiring nutrition labels on prepared foods, telling you the percentage of daily value in each serving. But over the time, the nature of the nutrition problem changed, shifting nutrition focus. Preventing deficiencies still matters, especially among the poor, but the focus has shifted to excess. The big killer now, cancer, cardiovascular disease, diabetes, are tied to nutritional excess, not lack. Some the message change: cut saturated fats and salt, eat more fruits, vegetables, and whole grain, and pay attention to your overall dietary pattern. The FDA even revised its labels to support these guidelines. So education sounds great, but does it actually work? Here is the superior part. Education has clear limits. Yes, smoking has declined, but 14% of adults still smoke, even though essentially everyone knows it's dangerous. So knowledge alone is not enough. And there is deeply troubling pattern hidden in that 14%. The people who still smoke are concentrated among already disadvantaged groups. Let me show you the disparities. Look at these gaps. By education, about 30% of adults with high school education or less smoke versus just 7% of college graduates. By income, 21% of those earning under 35,000 US dollar smoke versus 8% of those over 100,000 US dollar. By insurance, 25% of the uninsured of those on Medicaid smoke versus 10% with private insurance of Medicare. So smoking has become a marker of disadvantage. And that is a justice issue, not just a health one. Now let's check whether dietary education has done any better. The diet outcome. Diet is even harder to evaluate. People are notoriously unreliable when surveyed about what they eat. So improvement is a tough to verify. The decline in heart disease is encouraging, but at the same time, obesity has risen. So it's genuinely unclear whether Americans have actually changed how they eat. For a really striking case study of education's limits, look at the calorie labeling on the menus. Menu calorie labeling. Here is the natural experiment. In 2008, New York City started requiring chain restaurants to post calorie count. In California in 2009, and the Affordable Care Act extended it nationwide to change with a 20 plus location in 2010. Now you would think seeing 1220 calorie in a triple whopper with a cheese or 740 in a medium Oreo shake would change behavior, but the studies show menu calorie posting have, at best, a small effect on what people order. Information alone, again, is not enough. And sometimes education is not just ineffective, it is outright uh, contested. Even Benign seeming health messages can spark uh, fierce opposition, usually because someone's profits are at stake. The tobacco industry spent decades and vast resources disputing that smoking was harmful. The meat industry fought to delay recommendations to eat less meat. The sugar industry battled advice to cut sugar. So just educating peoples is never politically neutral. And no topic is more explosive than the next one: education in school. Schools are the obvious place to reach people early, to teach kids about diet, exercise, and the dangers of smoking, alcohol, and drugs. And the research shows school programs are genuinely effective at teaching the facts. But, and this is the recurring theme, it's far less clear that knowing the facts change how young people actually behave. And one school topic is particular has been a battleground for decades: advertising. Advertising can reinforce public health messages, but it is not an uphill fight. People are saturated with media promoting unhealthy behavior, cigarette advertisement, peer commercial, and others. Against that, fluid, occasionally public service announcement are frankly feeble weapons. Still, there are successes. Counter advertising about smoking helped cut rates in 1960s. And just say no campaigns was memorable, though whether it changed behavior is doubtful. There is also a clever newer twist in education worth knowing: the social norms approach. This is the social norms approach popular in college campuses to curb high risk drinking. It comes from 1980s, a study that found students believed their peers drank more than they actually did. So the fix is elegant: simply survey students and advertise the real number, correcting the everyone doing it illusion. Campuses have cut high risk drinking by up to 20% this way, fairly quickly. It's early, but uh, the proponents see uses for tobacco, seat belts, and risky sexual behavior too. One more challenge for education: your doctor. Health messages can also come straight from a physician during an office visit. Doctor managing chronic diseases like diabetes and asthma know that building inpatient education keeps people healthier. And while patients don't always follow doctor's orders, a physician's recommendation measurably increases the odds that people will change. That point to an important relationship between two fields: public health versus medicine. Here is the distinction to keep clear. Public health mission is to prevent disease, while medicine traditionally focuses on treatment and care or cure. But the two overlap because doctors often deliver public health messages. So public health has a job to do upstream, educating medical providers themselves about health risks and behavior. That wrap up education. Now we turn to the second, more forceful tool, the regulation. Government have always shaped behavior through law, and regulation is most clearly justified when its purpose is to stop people from harming others. Think about it. Laws against murder and assault are, in effect, public health laws, and nobody questions their legitimacy. Traffic laws are the same. We all accept stopping at red light and driving at safe speed. So, when the harm is to others, regulation is uncontroversial. Let's apply that to alcohol and tobacco. Most states in the United States regulate alcohol and tobacco for public health. Drunk driving laws are easy to justify. They protect others. Indoor smoking bans. Two, because second-hand smoke pollutes the air everyone breathes. And most adults support laws shielding children and teens, restricting their access to alcohol and tobacco. So far, so agreeable. But there is a point where consensus breaks down. Controversy over public health law is old news. In the 1800s, Britain and the United States fought bitterly over laws requiring smallpox immunization. In America, the issue reached the, the Supreme Court in 1905. Jacobson v. Commonwealth of Massachusetts, which upholds a state right to require vaccination for the common good. That phrase, the common good, is the entire philosophical foundation of regulatory public health. Another 20th century battle is loudly today: a prohibition. The 1919. The 1919 constitutional ban on making, selling, and using alcohol was the most ambitious attempt to the United States government ever made to regulate personal behavior. It was repeated just 14 years later, and the common wisdom is that it failed. But here is the twist I want you to, to wrestle with. We treat drugs like cocaine today almost exactly the way of the 18th Amendment treated alcohol. And few public health leaders will call for ending those prohibition. So the truth is more complicated, mixed results. Let's unpack them. A prohibition started as a late 20th century moral crusade. Alcohol was blamed for violence against wives and children, for crime, for, for sin itself. And public disapproval had already been cutting consumption before the amendment passed. Now, here is what surprised the student. During Prohibition, cirrhosis death fell to half the 1910 rate, and overall alcohol consumption dropped by two-thirds. So, in health ground, it actually worked. But fluating the law became socially acceptable, and organized crime flourished to meet the demand. That's dual legacy. Health gains versus social cost keeps re- resurfacing in a drug debate. In 2001, the National Academy of Science weighed in, arguing the prohibition like approach simply was not working. Their most damning finding: the federal government spends about 17 billion US dollar annually on drug enforcement, yet there is almost no information on whether it's effective. Drug arrest and uh, incarceration exploded since the 1980s, exceeding 2 million people since 1999, with about 2.2 million incarcerated in 2017, with no evidence this deters drug use. Their conclusion was blunt. Uh, and there are alternatives worth examining. Looking ahead. So where does this leave us? The clear takeaway is that education and regulation alone are not enough. Public health has to expand beyond them. The most promising work combines both tools, and we will see that combination applied to single biggest hazard on our list: tobacco. The next also promise a deeper theoretical look later at why people behave as they do. For now, let's consolidate everything in a conclusion. Let's recap. As infectious disease faded, public health focus shifted decisively toward behavior. The top three actual causes of death are smoking, poor diet, and physical inactivity and alcohol. And firearms, sexual behavior, motor vehicles, and illicit drugs use, and you have got the behavioral core of the top 9. The conclusion is inescapable. To cut premature death further, public health must find ways to change behavior. And we have examined is two main strategies. These two strategies are education and regulation. Education works best when genuinely new knowledge appears. Think of the 1964 smoking and health reports or food labeling. Regulation is effective but frequently unpopular. A prohibition, the, the boldest example, actually did improve healthy by cutting cirrhosis. But the prohibition style approach to today's illegal drugs has unproven benefits and enormous costs, both financial and human. And the deepest lesson from behavior science is this: health promotion works best when it targets individuals at many different levels of influence, not just one. Finally, this is a quick look at where this evidence comes from. This is the end of this chapter. Thank you for your attention and goodbye.